There's a lot of enthusiasm typically when physicians go to a conference or they hear about read about something in a medical journal. And it's, Friday afternoon when they're hearing it right from, the speaker on stage, it's like, this is going to change everything for me when I go back home. And then they get back home and it's Tuesday, Wednesday, and they get followed up with, you know, or they revisit something, they revisit the topic, and they're on an island all by themselves. They're back into the routine and they're as busy as they were, but kind of that stuff is still in the background. But, the enthusiasm on Friday has waned. And now it's like, we follow up or someone follows up about this and says, hey, I think you really should consider putting this into the practice, into the exam room. No, 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 no. That's not how we do things here. And that was great on Friday afternoon at a conference, but we don't do that. And I find that so many of the physicians we talk to, especially in concierge medicine, are so frustrated with that aspect of enthusiasm, where it's like, we talk a big game about being innovative and being that healthcare is moving so fast, but yet come Tuesday or Wednesday in traditional plan reimbursed practices, we find that there's this pushback, there's a tension that exists.
Yes, agreed. Yeah, no, I completely agree, which is why at their core, both of these blood tests, although yes, it's Friday afternoon and we love talking about the science behind it and the biomarkers and the artificial intelligence that was used to create the algorithms, et cetera. At their core, both of these blood tests are telling us something that we deal with every single day in the office, right? And when a patient comes to me in the office and says, I'm worried that my father died of a heart attack at age 50 and I'm 65 years old, and I'm worried about my cardiovascular risk factors. My LDL is 90, should it be lower? My blood glucose is fine, but my A1C is 5.7, should it be lower? Those are patients that are very common in our practice because, among concierge physicians, among folks like myself who have a very concierge-like practice at the MGH Heart Center, we have patients that are very well informed. They know where to find information about lowering their risk factors. But the question is that good enough? Are we delivering the kind of care that our patients, the individual patients sitting in front of us, should be receiving? We know that getting LDL under 100 is good. We also know that getting LDL under 70 for high-risk patients is better. We also know that in the Improve It study, getting LDLs under 50 for the highest risk patients, the really highest risk patients, is even better. We also know it's safe. We know that therapies like GLP-1 receptor agonists reduce atherothrombotic complications, even in people without diabetes. So ultimately, when it comes to our patient who's sitting in front of us, who is concerned about their individual picture, that's where tests like this can be really useful. Because at their core, it's kind of boring, right? I mean, one test tells you got coronary disease, one test tells you have a risk for an atherothrombotic complication. Simple answer. There's not a lot of nuance to the results that these tests tell us. But in and of itself, those results give us very actionable information. And no, my friends, in the medical world, we do not all lower our patients to LDLs under 50. We do not have all our patients at blood pressures of 130/80. The simple truth is a lot of our patients are resistant to that kind of aggressive treatment, but if given a reason to accept it, many more would be expected to accept it.